Thank you, Bhuvan, for including me in this IC, which we have been doing for the past 2 3 years, and this is one of the most popular ICs in Ureton. And as you can see from this flashback pic of 2019, a huge hall full of people even sitting on the stairs in this wonderfully conducted course. I'll be speaking on intraoperative globe hypotony, causes, sequelae, and management. No financial interest in any of the products used here. So, though rare complications related to retinal surgery can have serious, results, fortunately most are preventable. The most common complication which we have heard is perforation, light toxicity, drug toxicity, post-operative hypotony, iatrogenic tears, etc. But very little has been discussed and talked about intraoperative hypotony. It is rare because of modern VR tools and advanced fluidics, but it can occur in the hands of the most experienced surgeons using the most modern machinery. Early recognition and management in any complication prevents potentially devastating complications. So the basic denomination of intraoperative hypotony is, of course, the mismatch of infusion and aspiration, and that can be due to many causes: blocked or leaking infusion cannula, kinked cannula, your suction is high and it's not matching to the bottle height, active aspiration under air using non-valved cannulas, and of course accidental unnoticed infusion disinsertion while working under air using active aspiration or instrument exchange under air using non-valved cannulas. These are the many causes of mismatch of infusion and aspiration. And complications can occur because of intraoperative hypotony depending on the time initial to the just at the start of the surgery or the middle of the surgery, like bleeding, iatrogenic tears, lens touch, corneal edema, hazy view, submacular hemorrhages, especially in high myopes, and choroidal detachment. Coming to the management, the first line of management is to identify early signs of hypotony. Next is to identify the cause. And the last is to manage complications that have occurred because of this complication. Checking machine parameters, the bottle height, your infusion cannula, and a strong vigilance to the surrounding part of the surgical field. And of course, plugs should be placed in non-valved cannulas to secure fluid flow, airflow through the cannulas, which can prevent hypotony, especially in air-filled eyes. Coming to the videos of various incidences of intraoperative hypotony. This is a case of traumatic endophthalmitis, and it is an inflamed eye, and the block did not come well, and it's a shallow orbit, and the patient is squeezing the eye. Now, what is happening here? Sorry. What is happening here is because of the squeezing, the infusion pipe is it's just adjacent to the lid margin, and it's getting constantly kicked, and it's causing intraoperative hypotony. So always remember in shallow orbits or where there's a lot of squeeze, you take a break, you augment the block, whether external peribulbar or subtenon, like we did in this case. Make the patient comfortable so that the eye is wide open, and the cannula pipe is not touching the lid margin, it is not getting kinked. Here a posterior subtenon block is being given intraoperatively. And the surgery went off fine, the patient was comfortable, the doctor was comfortable, and the results were good. This is a video to highlight active aspiration causing intraoperative hypotony under air. So of course under air the pressure dynamics are different, and if you use active aspiration with the cutter, these are causes of intraoperative hypotony. This is a routine macular hole surgery, and after the ILM peeling, we are going under air and aspirating with the cutter. This video is just to highlight, you see, the active aspiration of the air causes this hypotony, and you can see the disc margin getting hypotenuse. So this is not of much consequence in this case, but if you are using that same maneuver in a diabetic case, and after the laser when you go under the air, and you are using too much excessive active aspiration with the cutter, it can cause resurgence of bleeding from the already cauterized breaks or bleeders or new bleeders, which can cause clot under the air and create a messy picture in a very well performed surgery in the end. So this was an active aspiration with the cutter under air in a diabetic vitrectomy, which can be of consequence. Of course, as we have discussed before, always use a 6 mm cannula if the tip is not visible, and even in some cases of dense vitreous hemorrhage or endophthalmitis, you might have to dissect tissue from the tip of the 6 mm cannula even. It might not be in the intravitreal space, even the 6 mm cannula. So you have to be sure to see the tip properly. Like we are going from the opposite side from the cannula, and we are using the trocar cannula to dissect the tissue from the tip of the 6 mm cannula. And we are sure that the tip is inside the vitreous cavity before starting the infusion. This is one case of a macular hole surgery again, in which another point to highlight is when you inject the dye to stain the macula and you wait for 30 seconds or 45 seconds and your instruments are perhaps out, and then you do not recheck while going inside that the infusion is in place. And that is what happened when we went inside during the peeling part. After the staining, we see this choroidal detachment because of a disinserted infusion cannula. Of course, we went off the surgery, reinserted the cannula, and the post-operative results were fine. So you have to always check while your instruments are out during a waiting period of 30 to 40 seconds during these macular surgeries. This video highlights an important point. This was a case of a dropped nucleus in which the IOL was placed in the sulcus by the operating surgeon and was referred to us. Now here what happens is, the first cannula is made. It's a walled cannula. The second cannula is made, the port is made. Now at this point, the ideal thing should have been to attach the infusion port. Just thinking that it's a walled cannula, it will not leak is a mistake, because some leakage is within the walled cannulas also. And secondly, it is a phaco done without any suture here. So some amount of indentation while pressing through the ports will cause the AC leakage, AC flattening, and the globe will be hypotenuse. Now, while making the third port with the MVR for a frag, you see the hypotony, and because of that, some trickle bleed or some bleed from the pars plicaita area, trickled into the posterior pole, and you can see that red reflex. So the infusion should have been placed immediately after making the infusion port. Of course, this could be handled in this case, but it can create a mess in the posterior pole and a hazy view during the phagofragmentation. These cases of myopic RDs are very notorious, high myopic RDs, pathological myopia. Even if you give pressure, putting a pinky or a hand pressure after giving a periorbital block, the choroidal capillaries are so fragile that they can, cause intraoperative subretinal choroidal bleeds. Like in this case, a small streak of bleed is of no consequence, and you don't have to aspirate as discussed in the previous presentation. But this is the second case of myopic RD, and you can see a massive subretinal hemorrhage encroaching the posterior pole is there, and you cannot leave that amount of bleed intraoperatively. So you have to make a large retinotomy, inject PFCL of the posterior pole so that the bleed is ironed out through the peripheral break, aspirated, and laser the retinotomy. So you can leave a streak of bleed subretinally after hypotenuse intraglobe hypotony, but you cannot leave a significant amount of blood intraoperatively. Another sequel of intraoperative hypotony. So this was a typical retinal detachment case, and we are proceeding in the usual way. And now we are coming to the PVD induction part, and we have injected tracard. Now you can see the telltale signs of intraoperative hypotony, as I mentioned in my comment from the previous speaker, that there is the whole fluid is static. There is no movement of the tricot crystals. The vitreous is not cutting properly, and your instruments are not obeying your foot switch actually. So there is something wrong, and we inspected, and there was a disinsertion or a kinking of the infusion cannula. We reinserted the infusion cannula. Everything went fine. Now what happens here is, after that, the media becomes suddenly hazy. The crystal clear picture before that event was not visible, and we could barely see the retina. So what happens is, while you are indenting in a hypotenuse eye, there is a lot of oozing from the iris root, which goes into the AC. So you don't need to debride the epithelium for that. Whenever there is an intraoperative hypotony and you resume the surgery, and there is a media haze, you go into the anterior chamber. You can see that diffuse blood in the anterior chamber, which was not there before. You just watch the AC and then go inside, and the view is again crystal clear as it was before the event. And of course, no amount of blood, significant blood should be left inside. And this was a referred case to us with intraoperative cannular disinsertion and the clot accumulates, it creates break, it contracts and it creates break, and there's a lot of PVR in the periphery, and it's very difficult, to dissect it, and finally you have to make a large retinectomy, relaxing retinectomy to settle the retina. So any amount of significant blood should not be left inside, or if left inside in the first go, should be immediately removed in a week or so, not left for a long time, so that the clot contracts and creates the iatrogenic breaks. This is the last video, and this is something where the intraoperative hypotony actually helped us. So this was a GA case of optic disc pit. It was an 8-year-old male, and as I said, there was the anesthesia went light, and there was a jerking on the patient's head, and the cannula got disinserted, and while our instruments were inside. So this is the PVD induction. So this is where the cannula got disinserted, and you can see the pulsations of the disc pit from this part, because there is intraoperative hypotony, and the negative pressure is allowing the fluid from the disc into the vitreous cavity. And here we could delineate the whole size of the pit because of the intraoperative hypotony, because of the pulsations. And then we reinserted the cannula, and the surgery went off fine. We did ILM peeling and inserted the ILM inside the pit, and the patient did fine post-operatively. So to conclude, infusion misdirection resulting in hypotony seems to be infrequent, but it remains a risk. Awareness of the problem is very important. The potential to touch the retina, choroid, the lens increases when there is intraoperative hypotony, and can be avoided by maintaining the correct position of cannula by simple measures like placing an external encourage. Valved cannulas surpass non-valved cannulas in maintaining IOP, of course, and early management of complications are key to success. Less things go out of hand because of intraoperative hypotony. Thank you so much.
The other two ports, and we remove the infusion port, and the whole globe collapses, and so.
Yeah, so that is because of two reasons. One, you have not made a biplanar incision in a case of 23-25 cannula, you have gone directly, or if your trocar cannulas are blunt and they are reused, so they are not making a perfectly sealed incision. So if that happens, normally what we do is some amount of conjunctiva coming after disinsertion of the cannula. That will help it. But still, if you are using used cannulas and there is hypotony, you can take a 30 gauge needle and inject some amount of air or gas at the end.
Does that not dilute the SF6 or C3F8
no,
that
I'll just like to first, I think Vishal has pointed everything. It can still happen if there is, scleral thinning or high myopic eyes. I think whenever we remove a silicone oil end, we do the air fluid exchange. I'm always scared of the hypotony happening, and it is also common. So you should not be afraid to apply a suture even in sutureless vitrectomies. So if you feel that your ports are leaking, you're above 2, it's always better. You can even pre-place a suture before removing the cannula. Or if there is a hypotony, you suture the leaking port, and you can inject again gas to reform. You have to reform the pressure once there is hypotony and you have closed all your ports. So you can reform it either through a 30 gauge, you can insert a separate. If there is hypotony, there's sometimes difficulty. So you can insert it through the same, the incision is there, and you can apply a suture. That is the only way you can prevent if a hypotony has already occurred. So the prevention is you can use better cannulas, do a better insertion, but still it can happen, especially in high myopic in scleral thinning, and you have to reform the eye and apply a suture.
So one way of checking and preventing this complication, what you mentioned is, in a gas-filled eye, while you are infusing the gas, keep the pressure on the higher side and then disinsert the cannulas. Now you just palpate and titrate the pressure, and that you can, if it is on the higher side at the end of the procedure, use a 30 gauge needle and aspirate the excess gas. Don't keep it hypotenuse.
I usually stop the air. Yeah. What I do is I stop the infusion and see whether my globe is collapsing or not, So if it is collapsing.
No, he's talking of after injecting the gas.
Okay, after.
While removing the cannulas at the end of the procedure.
The above 2 ports I'm talking, okay.
Yeah. Vishal, wonderful presentation, but what he's pointing out is, here's a catch there. We normally use a 50 cc syringe, dilute it and use it. He's saying is he's using a pure gas in a air-filled eye and injecting little bit so that as all of us Indians we want to save, so we use lesser. Is that right?
Partly, sir,
so.
but even
no, we have to be open. I do it sometimes. Yeah, we have done it.
So sometimes even the ISO expansile, even if you use a 20 cc syringe, it gets over by the time you
So that's why there is a French, we started doing that long time back. There was a French study which said 50 cc, go up to 35 cc so that you can get a isoexpansion cell. 15 cc is still left. That one is used for all these events. But the trouble is if you're using a 4 ml of cavity in which you have put in air and now you're injecting 0.3 cc C3F8 to save on money, then you are stuck. So then the only issue is what Bhuvan said, inject whatever gas you have to do, remove those 2 ports. Third port, take an Alabama in left hand or any forceps, use a LIMS forceps and exert pressure immediately and have some gas ready. That's the only way you can do that.
Sir, in 20 gauge days we used to apply the suture first.
Yeah.
Then while removing the infusion port, the assistant used to tighten it and the surgeon used to pull it out.
Right.
Pre-placed sutures.
Pre-placed suture. I think that will solve many problems.
Pre-closed sutures are very. Do you know, sometimes even if I feel that my eye after SOR have high chances of hypotony, I would still place a pre-placed suture and then go ahead with the. You can place a pre-placed with these systems also. They stay there.
But that post SOR hypotony is of actually no consequence if the retina is attached. It,
Yeah,
generally.
See, hypotony,
resolves
Vishal,
in
in
a
your
couple of
present.
days.
Yeah, I agree. If the retina is attached, but still hypotony can definitely lead to hemorrhage or a choroidal detachment,
Especially
recovery
in high
late.
myopes, you should always suture because the scleral rigidity is.
You should
very
not
less.
be. There is no shame in applying a suture in a even in a sutureless. 23G में तो लगाती थे, 25G में भी जरूरत है तो लगा लो. Yeah.
So may I add one point, sir? For hypotony, we are working in a dark room और बोतल खत्म हो गई. It's a long surgery and we didn't discover that the bottle is empty. Even there is some fluid left, the pressure is not there and the chances are that we are doing BVD induction.
This used to happen earlier a lot. Nowadays the machine keep on telling us that the fluid is getting empty. But you have to.
Not everybody has the higher
of course. Yeah,
Yes,
it's
sir.
always better. Yeah.
And one more point for the beginners is never
No,
depend
sir,
on.
the room is off and the surgeon is occupied elsewhere.
Sir, the assistants are. Assistant is never reliable. You have to check again and again by tilting your neck. So never rely on your assistant. He will say sorry, but the patient is yours. You will only have to be answerable.
Go by a gut feeling. When you're operating, if the hypotony is starting to develop, you have a different feel of the whole thing.
Yes, sir.
Then you immediately stop.
You goes down the moment the pressure has come down. From, let us say you have kept 30, it has become 22. अपनी यहाँ पर बत्ती और यहाँ बत्ती जल जाती.
Sir, you are quite experienced.
Sir, but normal.
If there is gas, sir, if your entries are perfect and not leaking.
If it is hypertonus, then it is cause of concern because there is a good chance of CRA occlusion. So I would want it to be normotonous. I would rather go with a 30 gauge and yeah. So it depends on the status of your ports and what is inside, whether it is fluid or not. Because with fluid, you can give a mannitol and it should be fine.
Thank you, sir. Any more questions from the audience, or can we please?
In one of my diabetic vitrectomy which required placement of silicone oil, in post-op period there was rebleed. So then how to go for it?
So under silicone oil there was a rebleed.
Yeah.
So see, first that depends. See, you can't laser. Of course, if there is a bleed, you can't laser. You have to wait for the hemorrhage to clear. But the important thing here is with silicone oil, with the bleed, the chances of increase in pressure are high because there is a closed globe. So you have to take care of the IOP in such a patient. And once the hemorrhage clears, you can go ahead for the laser. But if the hemorrhage is quite severe and the IOP is quite raised, then I think you have to operate again. You have to remove the silicone oil, you have to clear the blood, you have to stop the bleeding and then do the laser. You can't leave an eye in a diabetic eye with a pressure of more than 30 or 40, and these pressures will not get controlled with any medication, because it is a closed globe. You have already put silicone oil, and there is also a hemorrhage now. So it will eventually lead to optic atrophy. It can also lead to blindness. So I think you should not leave a diabetic eye with a pressure of more than 30 for more than 3 to 4 days.
Yeah, so
That, so,
they need to go inside.
Yeah, it's not very bad. Like I can see, but
yeah, if the hemorrhage is small, the pressure is fine, then you can wait, of course.
So you have
mild
to.
details and the pressure is under control, you can observe.
okay. So pressure will be like guiding
So you have to
guiding
define
parameter for these cases.
You have to define the size of the hemorrhage, the location of the hemorrhage. If it is away from the macula, small hemorrhage, and you do not need to give particular tamponade, you put in oil, complete your laser, try to remove silicone oil early, make the patient sit up. And I do not know how many of you, I've had 2 situations recently where I had a similar situation, a small bleed, and surprisingly the blood is in the perisilicon's place and is not clotting. The moment patient lies down, becomes submacular. The moment patient sits up, goes down. I just can't understand what is the logic. So in such a situation, I told him that I make him sit up, it goes down, because this is true for any cavity which has got like a pleural effusion. If you have fluid, it will not clot. So similarly in the eye, if you have 2 membranes between silicone oil and retina, it may not clot. That's the logic I have. So this is not clotting, so I make him sit up. Whenever he's ready for it, we'll remove the silicone oil.
See, if your IOP is fine, I think you should wait for 2 weeks. There is no problem, because the hemorrhage will as such will not cause any problem.
Yes.
If your retina is fine, your retina is flat, you have done a laser, hemorrhage will not cause a problem. I think the main thing is the pressure. You can wait for 2 weeks.
So it's the role of anti-VEGF.
Of course, pre-operative anti-VEGF. See, post-operative anti-VEGF at the end of the day, I don't think has any role, because in a vitrectomized eye, it will usually washed off. With silicone oil, if a fresh bleeding has occurred under silicone oil, then you have to be very careful if you're giving an anti-VEGF, because the short life is reduced. So a half dose anti-VEGF is usually recommended if it is once clear and you feel that a fresh bleeding is happening. I think then only there is a role of anti-VEGF under silicone oil.
Thank you.
In a diabetic case, more they require probably in PCVs or CNVM, these anti-VEGF are more needed.
If you do the operation, at the end of this operation, you find there is no leak, and in the first day of the post-operative, you find this eye is hypotenuse. What's the ideal way to deal with it? To wait and see what's happened, or early intervene?
So day 1, if we have got a hypotenuse eye, again I think it depends on how much hypotony you have, and what is the state. If the retina is attached and there is a hypotony with mild choroidal detachments, probably I think you can wait. You can give a pressure bandage. You can start oral steroids, and you can wait. You can observe the eye for 3 to 4 days and see whether the pressure is building up. But if there is a very severe hypotony and the globe is completely collapsed, then you have to go inside. You have to form the globe. Otherwise, it can lead to serious complications. Any other comments?
A pressure patch for 24 hours will do the job. If it does not, then you have to go.
And stop all anti-glaucoma agents.
Yes.